Good morning, my respected delegates and my friends. Today I'm going to present before you the low-dose RANIBIZUMAB in the treatment of aggressive retinopathy of prematurity in India. So we all know what is AROP. It is the most aggressive form of ROP as it directly progresses to retinal detachment without going to the normal stages of ROP, and its meticulous management right from the beginning is very important hence. There has been gradual evolution in the treatment approach of AROP. Previously it was ETROP had set forth of laser and cryotherapy as the mainstay of the treatment, but in those cases, in AROP cases, large areas of laser and cryo need to be happen, and that caused high myopia, high astigmatism, and hence strabismus and amblyopia. Next, the anti-VEGFs gave a new breakthrough, and the first anti-VEGF that came was bevacizumab, but then bevacizumab had risk of systemic side effects due to systemic penetration of the drug, and hence its use was hindered. Next, the ranibizumab gave again another breakthrough, but though its systemic side effect was almost nil because of nil systemic absorption, but since due to its shorter half-life, there was again a recurrence rate is high. And requirement of secondary laser photocoagulation is also required in a large number of babies, because a large number of babies is seen to have avascularity right from zone 2. The requirement of secondary photocoagulation after ranibizumab is almost 80%. Recently, CARE-ROP study done in Germany has given a new breakthrough, because that has gone through the application of low-dose ranibizumab in the treatment of ROP, and it has shown promising results because of good vascularization potential as well as good effectiveness in controlling the acute disease. So here lies my rationality of the study and as well as my objective, where I have tried to show, I have shown the comparison has been done between the normal dose and the low dose in terms of recurrence and vascularization status. So my study was an interventional trial, academic interventional trial. No financial interest was there, and all ethical committee clearance was taken. And I have taken my sample size as 34, and I have taken AROP babies, and both zone 1 AROP and zone 2 posterior AROP has been selected. And purposefully what I have done is that in both the groups I have equally divided the zone 1 AROP cases and zone 2 posterior AROP cases, maintaining all my inclusion and exclusion criteria. So these are my results and analysis. My results and analysis are in terms of recurrence, complete vascularization status, as well as incomplete vascularization with or without ROP. So coming to my recurrence status, what I have seen is that in recurrence with low dose, in recurrence with normal dose, here I have seen, here in recurrence with normal dose, there is odds risk estimate of 2.13 more recurrence than that of the low dose in cases of zone 1 ROP. In the zone 2 posterior ROP cases, what we have seen is that with the, because it contains zero value, so odds ratio calculation was not possible. We have calculated the confidence interval, and that found to be significant, in signifying that normal dose zone 2 in zone 2 posterior ROP is seen to have more recurrence values than the low dose. So here is a picture of recurrence of AROP. The complete vascularization analysis, when it was done, it was seen that in both the groups, both zone 1 and zone 2 posterior AROPs, in both of them, the low dose had significant good vascularization status than those of the normal dose. And here you can see that zone 1 AROP has good, very good vascularized up till zone 3, up till aura. And next, coming to the incomplete vascularization status, what we have seen is that in this case, the zone 1 AROP cases with normal dose has seen to have more persistent avascularity than that of the low dose, and that is 2.3 times higher odds risk ratio. But that is not in the cases of the zone 2 posterior AROP. That has not shown any significance. So in discussion, at last I want to show you some important facts that with low dose, we have got in zone 2 posterior AROP complete vascularization. But in the cases of zone 1 AROP, what we have found is that the eyes which are remaining persistently avascular, only the zone 3 area is remaining persistent as avascular, not any other areas. So ultimately I am requiring very much.
Please conclude. The time is.
Ultimately I am requiring very much lesser area to laser. But it is not in the cases of the normal dose, because the eyes which are remaining persistent avascular, they are having both those avasculating in zone 2 and zone 3. So still normal dose is requiring a large area to be lasered. So here you can see I have lasered one to low dose and only the zone 3 has been lasered. So it is a very small area. So my conclusion is that yes, low dose ranibizumab is really found promising with good vascularization status in AROP cases, and in the long run requirement of laser with unforeseen consequences both in terms of systemic and visual risk can be lessened. And of course, last but not the least, it is very cost effective also. So my limitation is only small sample size and single center evaluation. Thank you.
Thank you.
Since the ranibizumab,
Yes. Yes, ma'am. Maximum, I have given two injections.
2 for each, for zone 2, zone 1, everybody.
No, zone 1. Ma'am, actually what happened, if you have seen that it has approached zone 2 and more, then we have not applied second time injection. We have done the laser. But if a recurrence happened in zone 1 only, then we had to give another time injection just to avoid large areas of laser application.
So how many in your study you had to go for laser also?
How many I have to do the laser? Ma'am, it is in the normal doses, it was as much as 80%, ma'am, because not in the low doses. Low doses is hardly 40%, when as a whole, considering both zone 1 and zone 2 posterior did not require any laser, only the zone 1 cases of the 40% only. Thank you, ma'am.
Thank you.